Good evening to everybody, or good afternoon, depending on where you're at. First of all, I'd like to thank everybody for attending this webinar. I see from looking through the, scrolling down here on the list of attendees, we've got people from, of course, the U.S., but Europe, South America, different parts of Asia, the Middle East, and I thank you for your interest in safety and infection control. My name is Carson Carpenter. I'm a dentist. I'm actually a practicing dentist. The things I'm going to talk about today, I don't just lecture about, I do them every day in my practice. And I feel really strongly about the things we're going to talk about today because I think it can make yours a better practice and a safer practice for everybody involved, patients, staff, and yourself. So first of all, keep in mind that I did do part one of this webinar back a little over a month ago, and that it is archived on the Viva Learning site. So you can certainly access that and review it for any of the things that you may have missed. So let's get started here with tonight's seminar. First of all, what are we going to talk about? Well, some of the learning objectives we're going to review the infection control regulations and guidelines, and even for those of you that are in other countries, these guidelines are quite consistent with many of your regulations and infection control guidelines as well. So please don't think these are just for the United States. We're going to talk about the role of the environment in the transmission of pathogens, learn about disinfectants and surface compatibilities because we all have a lot of valuable equipment that we don't want to damage, and actually develop cleaning and disinfection protocols so we get some consistency in your practice. So infection control strategies. First of all, keep in mind that infection control isn't just in the office. We all go home. We all have not only staff, friends, and family, but we have our patients. And these things can be spread laterally and vertically from the different places we go. Some of the things that allow you to practice safe dentistry, of course, some of it's common sense, but a lot of the guidelines come from, for example, the Centers for Disease Control, OSHA, your state or national dental board, best practices from organizations that for example, I'm a member of, like OSAP, training in your office, the fact that you want to do a good job, doing the best that you can. And of course, the unique nature of your office and continuing education, which tonight is part of. Some of the key pathogens in dentistry include viral hepatitis. That would be hepatitis B and hepatitis C. Keep in mind that probably every one of you is seeing at least one hepatitis B patient a week in your office, maybe more. For hepatitis C, keep in mind that most people show no symptoms. 70 to 80% of them show no symptoms. And outbreaks of hepatitis B and C have been reported in dental offices. HIV, there's over 1 million people infected in the United States alone, and symptoms might not show up for over 10 years. So you think you're not seeing HIV patients, but you are. Tuberculosis. Tuberculosis doesn't get a lot of discussion in dental offices, but it is an airborne disease. It's spread when people cough or sneeze or laugh, or aerosols are developed in the office. And there's latent TB, where people aren't actually sick and they're not infectious, and the actual TB disease itself. All pathogens you have to be concerned with in dentistry, as well as MRSA, or methicillin-resistant Staph aureus. It's carried by 2% of adults, and it is found on surfaces in the dental office. In fact, some slides I'm going to show you in a little bit, you'll be surprised what a high percentage of offices test positive for this. Some of the guidelines you should be concerned with, and again, this would be even if you're not in the United States, are OSHA guidelines. And some of the keys are recognizing hazards, and then OSHA's actual bloodborne pathogen standard, which gives us some guidelines for safety in the office. The Centers for Disease Control, although the guidelines were written in 2003, there was a summary of them, and I guess I'll call it a reinterpretation of them in 2016. And these are some of the things we're going to talk about as well. Also, your state and national in the case of other countries, dental boards, your departments of public health. They can enforce these CDC guidelines, and they also have some specific requirements. Keep in mind, too, that OSHA can enforce CDC guidelines. Some people tell me, well, the CDC are just guidelines. I don't have to worry about those, but they do. They're considered really the standard of care. And OSHA enforces these CDC guidelines under what's called the General Duty Clause, or I call it the Common Sense Clause, and state dental boards can enforce them as well. The cost of an infection in your office can be extremely high. There were 5 outbreak-associated infections in 2009 in a dental clinic that was well documented. 1,500 individuals were notified and had to be screened. And then in 2013, there was one that made news, national news here in the U.S. in Tulsa, Oklahoma. 89 people tested positive from that oral surgery practice for hepatitis. 4 tested positive for HIV, and 7,000 patients were notified and had to be screened. You can imagine this is really a nightmare for a business and also a nightmare for the patients themselves. Financial cost. Stop and think about it. Here in the U.S., a dentist not working for an hour, typically in their business, they produce close to $700 per hour. If a hygienist isn't working, we're talking about $200 an hour. And what about the dental team, the assistants, front desk people? Their time is invaluable. Reputational costs. How would you like to have your practice featured in a news article for an outbreak of infection? Or a public health department investigation, or a dental license suspended, your office closed. Also, there can be liability associated with it. And I don't know about you, but here in Michigan where I practice, we have all the same problems that you probably do. Decreased reimbursement from insurance companies, increased competition. One thing we don't need to do is read about our practice in a negative light. Infection control, bad infection control, or lack of infection control can destroy a business. Some of the principles we're going to talk about are taking action to stay healthy, minimizing contact with blood and body fluids, using whatever we can to make the office safer and limiting contamination. And some of the strategies to accomplish this would be, first of all, considering standard precautions. That just means treating everybody as if they have a disease. Doesn't matter if it's your best friend, doesn't matter if it's a family member, doesn't matter if it's somebody who you suspect is an IV drug abuser. You treat them all the same, using any engineering controls that we can. So anything mechanical, any mechanical device that can make it safer, like a needle recapper or a scalpel blade remover or a cassette system. Maybe you use an instrument washer, an ultrasonic, any mechanical device. And then just behaviors in your practice, which often have to be taught, and that's part of tonight, like hand washing and environmental disinfection. Also, personal protective equipment, you always have to consider that. We're talking about things like masks, gloves, protective eyewear, long sleeve clothing, all things that make it safer for you and your staff. So the role of the environment. In a dental office, pathogens can be found in blood, they can be found in saliva or other body fluids. And transmission can occur in a variety of ways. Could be your equipment being contaminated, contact with skin, punctures with dental instruments, contact with mucous membranes, so the eyes, the mouth, the nose. Bacterial contamination in dental offices. Here's the results from 11 dental practices. Bacteria were isolated from surfaces inside and outside patient care areas. So remember, we're not talking about just the operatory, but we're also talking about the waiting room. We're talking about non-clinical areas, break rooms, lunch rooms, etc. And take a look at this chart. This lists the percent of surfaces that were contaminated either with all coliform bacteria or E. coli. The dentist's chair, 76% were contaminated. The patient's arm, the arms on their chair in waiting rooms, over 70%. If you take a look at this, an average of at least 60-65% of surfaces were contaminated with these pathogens. Common pathogens can survive on surfaces for days, weeks, even months. And if you take a look at these, several of these bacteria and viruses can be found in saliva, can be cultured in saliva. So I take these things really seriously. And when you look at the surface viability on the right, look at this, days to months. Some of these things are going to be there for a long time unless you take action to clean them, disinfect them. Touching dirty surfaces can recontaminate clean hands and further spread pathogens. And remember that hepatitis B and hepatitis C have been reported, outbreaks have been reported in dental offices, and MRSA transmission has been documented in a study in the United Kingdom. Ultrasonic scaling and other dental treatments. We create aerosols all the time, contaminate surfaces with streptococci. So cleaning and disinfection. First of all, cleaning, we're talking about the actual mechanical removal of organic and inorganic soil from instruments and surfaces. So an example would be cleaning the instruments before you autoclave them. Either maybe it's hand cleaning, maybe it's in an ultrasonic, maybe it's in an instrument washer. You also hear the term sanitization, and that's reduction of the number of bacterial contaminants to safe levels. For example, sanitizing break room countertops. And disinfection, that's an inactivation or destruction of pathogenic organisms. Normally you're doing that with chemical agents like the ones we're going to talk about tonight. And a typical example is disinfecting operatory surfaces after you've seen a patient. And sterilization. Sterilization means a process where you're actually killing all life forms. For example, autoclaving instruments. I'm sure you've all heard of Spalding's classification, critical, semi-critical, and non-critical. Basically, critical items are those where they penetrate soft tissue, like a perioscalar or endophile, and they need to be sterilized. Semi-critical items, these are things that contact mucous membranes, like touching the inside of the mouth, or they touch non-intact skin. So you'd be talking about impression material, impression trays, mouth mirrors. And again, sterilization is the standard of care or a minimum high-level disinfection. And non-critical items, these are things that contact intact skin. For example, non-critical items might be the dental delivery unit, the lead apron, a pulse oximeter, a blood pressure cuff. And here, low to intermediate level disinfection can be used. Here was a study actually conducted at the University of Arizona of 11 dental practices. And they actually took these surfaces before any type of disinfection and tried to see what type of bacteria they could isolate from them. And coliforms, E. coli, and MRSA were all found before. Afterwards, in this case, it was using a hydrogen peroxide cleaner disinfectant wipe. There were no coliforms, no E. coli, or no MRSA detected on the surfaces. So we've got to think about not only these clinical surfaces, like in the operatory, but the other surfaces found in the offices, and that we can make a very positive impact with our infection control program, as you can see by these numbers. Let's talk a little bit about surface disinfectants and surface compatibility. First of all, I want to give you a little guidance in how to pick a disinfectant. Often people ask me, well, which product should I use? And I'll say to them, you know, it's not just about giving you a name. I want you to become kind of a detective and start to read labels and start to think about, well, what kind of product do I need? First of all, It's great if it has broad spectrum antimicrobial activity, like intermediate level activity. It should act fairly quickly. But that being said, don't choose it just on time. If something can do it in a couple, 2, 3, 4 minutes, I'm fine. Surfaces need to be kept wet. This is a real problem with some, for example, wipes I've seen where they don't keep the surface wet. It needs to be compatible with your surfaces. I don't have to tell you how expensive dental equipment is. Not only equipment, but the countertops and surfaces. It needs to be something that's not going to destroy your surfaces. It needs to have an acceptable odor and non-toxic so the staff will want to use it. It needs to be simple to use. Of course, cost is always a concern. It needs to have a persistent activity. It needs to be non-flammable, water-soluble, stable, and you also have the ability to clean surfaces. So what you're doing is you're doing a balancing act, right? You're balancing, you want something that's fast-acting, preferably intermediate level, but you want to have low residue and surface compatible so you're not destroying your valuable equipment. CDC levels of chemical disinfection. There's high level, intermediate level, and low level. And don't forget, too, that these charts, I know that in a webinar like this, you can't go over all the details on a chart like this, but remember that these things will be archived starting within a couple days on the Viva Learning website, so you can look a little bit closer at some of these things. But a high-level sterilant, its functions to cold sterilize heat-sensitive items like plastic suction tips, brush handles, cheek retractors. Intermediate level, the goal here is to clean and disinfect surfaces that might be contaminated with blood or body fluid, like surgery counters, dental chairs, equipment trays, tables. And an intermediate level is able to kill TB, and we'll go over that in a little bit. Low-level disinfectants, the goal here is to clean and disinfect surfaces that aren't likely to be contaminated with blood or body fluids, like reception counters, chairs, desks, staff work areas. Typically, high-level sterilants are going to be either LPAs, glutaraldehydes, some hydrogen peroxide products. Intermediate levels, you're going to find the chemistry in there is often improved or activated hydrogen peroxide, some quaternary ammonium compounds mixed with alcohol, and some sodium hypochlorites, particularly the new generation ones. Low levels are typically quaternary ammonium compounds. The efficacy of these disinfectants. First of all, hospital or healthcare disinfectants. The language you're going to look for on a label is typically going to say for use in healthcare settings. And the key is that they're able to kill Staph aureus and Pseudomonas. And these are the types of things you should be using in your dental office. OSHA bloodborne pathogen standard, they call for what they call a appropriate disinfectant. And in this case, we're talking about something that kills HIV, hepatitis B virus, and is tuberculocidal. Common chemistries that you'll see, they're referred to often as quats, quaternary ammonium compounds, alcohols, bleach, sodium hypochlorite. Some of the newer entrants that you're going to see out there, some of the products that we use and we'll talk about are new generation bleaches. Bleach has always had a bad rep because they smelled bad. They did a great job, but they destroyed equipment. Some of the newer ones, like the Clorox products, are a hypochlorite, hypochlorous acid mixture. They don't have the smell. They don't destroy your equipment. Also improved hydrogen peroxides. And then some of the older chemistries that you see, iodophores and phenolics. So these are really the categories that are out there. Remember I'm always going to say it, I'm going to say it several times tonight to read the label. First of all, you'll see here the antimicrobial activity kills microbes. For example, it says bacteria, viruses, fungi. That's why you want to read the labels. Surfactants, these are able to solubilize soils and aid in actual cleaning of the surface. Special additives on fragrances. That's what you're going to see in a typical label like this one on this Clorox Fusion product. So what's the relevance of a TB disinfection claim? I often get asked about this because you see TB isn't really a problem. There's really little evidence of transmission via contaminated surfaces. It's an airborne disease. So why is the TB claim relevant? Well, from the CDC, this is a quote from the CDC, the ability to kill Mycobacterium tuberculosis is used as a benchmark to measure how well a disinfectant can kill germs. So Mycobacterium tuberculosis have among the highest levels of resistance of all microorganisms. So Mycobacterium bovis is a surrogate organism that's used. The EPA-registered tuberculosidal disinfectant claims are not a surrogate for a disinfectant's efficacy against other bacteria, viruses, and fungi. So what all this means is the label claims for use in a healthcare setting are really the key thing that I'm looking for. You want to look at a product label, and you want to make sure that you have an EPA-registered disinfectant claim against the common things you're going to find in your practice, like MRSA, E. coli, the common bloodborne pathogens. In that sense, TB is maybe not as an important of a kill claim as you might think. The CDC says I need an intermediate level disinfectant. You'll see this question often. Why is that classification not included on the label? Well, first of all, the EPA regulates healthcare disinfectants. Labels will contain lists of pathogens that the product is approved to kill. And general claims of the product being a specific class of disinfectant will not be listed on the label. So in other words, you want to actually look at that label. You want to select an EPA-registered disinfectant with label claims for healthcare use. So you want to start to read the label yourself. It's not necessarily going to say intermediate level disinfectant. You may find that on some of the marketing materials, but not actually on the label itself. For example, take a look at this label. You'll see here that it says tuberculosis, that there is a TB kill time. So in this case, it's an intermediate level disinfectant. But take a look also at the organisms that it will kill. I want to encourage you to not just ask your rep, what should I buy? But look at that label. The other thing you want to look at is surface compatibility. As you can see here, it's very important to make certain that what you're using is surface compatible. Take a look at some of the costs that we have here. First of all, a dental chair, you're talking $5,000 to $8,000. It should have well taken care of a lifespan of 12 to 15 years. Your dental delivery unit, $6,000 to $9,000. Again, 12 to 15 year lifespan. Your operatory, cabinetry, and countertops, again, very expensive per room. You could be looking at $4,000 or $5,000 with a 15 to 18 year lifespan. X-ray equipment, big time expense here. And with improper care with harsh disinfectants, the useful life can be greatly diminished. Okay, so how do I ensure I'm doing the right thing? Well, where to start? First of all, how should I clean a particular surface? First of all, you want to look at your instructions for use on your equipment. You want to look at your product labels. You want to talk to people who are familiar with the disinfectants. One of the reasons I use the Clorox product is it's very easy to read on there if it's surface compatible. So if you don't know the materials used in your practice's equipment and surfaces, you want to evaluate the compatibility. Read the cleaning and care guidelines for your equipment. For example, common surfaces you're going to find in dentistry. Countertops might be made of Formica, corian, stainless steel, sealed stone. Sinks are obviously ceramic, porcelain, or stainless steel. Your dental chair, it'll often say ultra leather or naugahyde. Dental assistant stools and doctor stools are typically made of plastics like PVC, ABS. Some of your cabinetries, laminates, dental lights are plastics, dental tubing, PVCs. So you want to be looking again at your disinfectants to see, are they acceptable with these surfaces I have in my office? Evaluate the disinfectant or evaluate the surface compatibility. For example, take a look at this label. It says on here specifically what things you can use it on. It says specifically what things you shouldn't use it on. So pick up the label, look at it. Don't only rely on your rep for which disinfectant you should use. This happens to be the Clorox 3-star system. What I like about it is if things are rated 2 or 3 stars, they're extremely surface compatible. For example, the 3 stars, there's no visible surface damage or effect on the materials. So take a look at the bottles. If they don't have a system like this, I would consider the Clorox products for surface compatibility. Also, there are many manufacturing endorsements. Midmark, for example, endorses the Clorox products. Now, what about some of the other things that you might not even think about? Like what about, for example, curing lights? If you take a look closely on the instructions for use, it will say things like water-based disinfectant solutions are preferred. Alcohol-based disinfectant solutions may be harmful and discolor plastic materials. So again, I'm going to encourage you to read the instructions for use on the products that you have and then balance that efficacy and the compatibility. For example, this is a product that I've been using in my office. It's coming to market soon. It's called VersaSure. It has a low residue. It's very surface compatible. It's a one-step cleaner disinfectant in its intermediate level. Of course, when I say one step, that's something that can clean and disinfect in one step. Next, let's talk about cleaning and disinfection best practices. One of the things that you're going to want to do is you're going to want to educate your staff. If you're not having regular infection control meetings, I'm really going to encourage you to do it. First of all, pick someone in your office to be the team leader, maybe a trusted hygienist, a trusted assistant. Set meeting times and review infection control guidelines as a team. And let everybody know they're all important in protecting the practice, protecting themselves, protecting the patients, protecting your equipment. Set some really clear goals that you want to have, and set these meetings from time to time, not just once a year, but I would suggest at least quarterly. Maybe you make it part of your annual OSHA training, for example. Make sure, too, at the end of the session that you do have a question and answer session. Because people are going to have questions about what type of disinfectant do I use, what type of cleaner do I use, how do I use it. A great guideline are the CDC infection control or infection prevention and control guidelines and recommendations. This really sets the guideline for your practice. For example, a written cleaning schedule. If you don't have one, you should. It's actually something that our OSHA regulations require. You want to actually have a posted schedule so people know what items do you clean, when do you clean them, what do you use, which product do you use. So formalize all of these things. I mean, actually have them written out. And what about surface barriers? People often ask me, well, should I barrier cover something? Should I disinfect it? Well, surface barriers should be used on items that are difficult to disinfect, but they need to be changed between patients. I highly recommend them. And have this as part of your written protocol as well, so people know where you use barriers, where you use disinfectants, where you use both. For example, barrier protected surfaces should be cleaned at the end of the day or when they're visibly soiled. You actually need to have these type of things written out. What I find in infection control is if you don't have written guidelines, if you don't have meetings, it's pretty hard to establish a culture of safety. Best practices for disinfecting surfaces: first of all, select the right product. Make sure that it's compatible with the surfaces in your practice. Make sure that you first of all decide, do you want to spray or do you want to wipe? Wipes are extremely popular today. One of the reasons that I've used, for full disclosure, I do represent Clorox, but I've also used Clorox products for many years before I was ever associated with them. One of the things I like about the Clorox product, besides the recognizable name, I like the fact that their wipes are available in various sizes. I like the fact that they stay wet. Many times wipes that I've used, I wipe the surface and I look and it's quickly drying. Well, if you have a 2-minute contact time and it's drying before 2 minutes, you're not accomplishing the job that you want. Also, try to pick one that's a one-step. You want something that will clean and disinfect and do it all in one step. So read the labels, follow the instructions for use, and also think about residue on your equipment too. After disinfection contact time has been reached, wipe down the surfaces with a clean, damp cloth to remove any visible residue. Keep your equipment looking good. Any type of disinfectant that you have is going to have some type of potential for residue. I don't really find it to be a problem in my practice. Here's an example: laboratory testing results simulating daily disinfection on acrylic surfaces with different disinfectant wipes over a 6-month period. And you can see that there are some residues, for example, with quad alcohols, hydrogen peroxides, and bleach. And in most cases, again, residues can be removed with a clean, damp cloth. So another question we often get asked is, how do I know if a disinfectant is a 1 or a 2-step? First of all, many of the disinfectants on the market today are 1-step, meaning that they've demonstrated the ability to be used in the presence of soil. So review your disinfectant instructions to ensure you're using it the right way. Even if you have a 1-step, EPA requires that you, in fact, clean any gross filth first prior to use. Typically in a dental office, that's not a problem. The Clorox disinfecting wipes that we use, you wipe the surface, let it stay on for the proper contact time, and move on to the next step. So again, I'm going to encourage you to try to pick a 1-step just to make it easier for your staff. Clinical contact surfaces, they have a high potential. They're really defined as anything that has a high potential for direct contact or contamination from spray, splatter, instruments, or gloved hands. Our direct contact with patients and staff includes most of the surfaces in the operatory, but if you actually look at the CDC guidelines, things that they list as being potentially clinical contact surfaces would be light handles, switches, dental radiographic equipment, chair-side computers, drawer handles, faucet handles. But they also list things like pens, telephones, and doorknobs. Now you know yourself, you don't have to touch half of the items on here. To me, one of the best infection control techniques is to simply take off your gloves and not touch things like pens, telephones, doorknobs, or drawer handles with dirty hands. So when to clean and disinfect? First of all, between patients. And what you want to do is, of course, again, barrier wrap. Any areas that are difficult to clean, remove and discard them, wearing gloves. Inspect the surfaces for soil or contamination. Without barrier protection, you simply have to clean and disinfect between patients. What should you use? Again, a detergent-based cleaner, an EPA-registered disinfectant. It's hospital grade. I like them to have a TB claim, an intermediate level disinfectant, and wearing gloves and other appropriate personal protective equipment. Remember, I know you're used to wearing gloves, masks, glasses, and long sleeve clothing when you're treating patients. You want to do the same thing when you're handling any disinfectant. You know, one note that we put down here in red, every now and then people will ask about chemical sterilants or high-level disinfectants. You don't want to use them on clinical contact surfaces in the operative. They'll definitely destroy your equipment. Now, as it says here, high-level disinfectants are classified as sterilants, which are required to inactivate all bacteria, not just a high percentage of them. And again, if you take a look on here on a product like this product, they're definitely not designed for contact surfaces in the operatory. So again, you're going to have several different products in your office. Read the label. Make sure you're using the right one on your valuable countertops, dental chairs, etc. So always follow your manufacturer's cleaning and disinfection guidelines. Use the manufacturer recommended products and the appropriate personal protective equipment. Electronic equipment. If you're concerned about residue, wipe with a damp cloth. X-ray aprons. Quats, like low or intermediate level disinfectants, are a good choice. Again, rinse and dry after use and you won't destroy the plastic on them. Digital sensors, intraoral cameras. I find that with digital sensors, the best thing, of course, you always want to use a barrier over them. But in addition, you do need to clean and disinfect. So clean with the detergent to remove any visible soil. Wipe with the appropriate disinfectant. Again, an intermediate level you're going to want to use. And one thing I like people to understand is that according to the CDC, for digital sensors, you need to be using a barrier and using an intermediate level disinfectant. You need to do both. So even though you're barrier wrapping, you still want to wipe it with your intermediate level disinfectant between patients. Housekeeping surfaces. These are surfaces that have a low potential for direct contact or contamination. We're talking about things like floors, walls, office areas, unused counter spaces. But still, there is a potential for contamination. So what should you use? Well, first of all, detergent-based cleaners, EPA-registered disinfectants. Remember that mops and cloths, they need to be cleaned and dried after each use, or they need to be single-use. Remember to prepare fresh cleaning solutions daily. And again, you don't want to use ever a liquid chemical sterilant or a high-level disinfectant on something like this. So what are some of the key takeaways? You can see that I really focused an awful lot on my concern for your valuable equipment. I mean, I want to balance that fine line between doing the right job but not destroying the valuable metal, plastic, acrylic surfaces. So surfaces are potential sources of transmission, and these pathogens can live on them for long periods. But you need to know when and what to clean. And I think a good place to start is that Spalding classification of critical, semi-critical, and non-critical. Clinical, so the surfaces you actually touch, and housekeeping surfaces need attention to avoid the spread of pathogens. You really want to take a look at the chemistry, the efficacy, the material compatibility when you're looking at surface disinfectants. What are the pathogens of concern? Review the product labels and any other technical information before using the disinfectants. Don't just, you may be used to using one disinfectant or one wipe that you've used for a long time. It may have been years since you really looked at the label. Take a look at that label tomorrow. See what you're using. See if there isn't a product that could be better. Maybe something that could do the job better, faster, and not destroy your equipment. And once you decide what you're going to use, actually have a protocol, and I'm talking about a written protocol for cleaning and disinfection. It would include what type of personal protective equipment to use, what products to use. And as I mentioned, it's not just product-based. One of the best infection control methods I've ever seen is simply remembering to take off gloves when you're going to touch things. Because if you don't touch things, they're no longer a clinical contact surface. Also, education and training are critical. What I found with our team is if we don't have education on a regular basis, things fall apart. It's just human nature. And you know, you're going to get new staff members in from time to time. And even if you have a consistent staff, you need to have regular training, at least quarterly, some type of training, maybe even for an hour. And certainly your annual OSHA training, infection control training, which is probably going to take about 2 hours. And also working together as a team to keep the practice safe. I always say that if you're going to have a culture of safety, you have to have communication. That means that you give everybody the license to remind someone when they're not doing it right. And that means even if it's the doctor. If you see the doctors going down the hallway, wearing gloves that were used in the operatory, or wearing a mask, or not wearing their safety glasses, you need to remind them. Staff, you need to remind each other. You can't take it personally. If you're going to have a culture of safety, you've got to have open communication. As I mentioned, too, our resources are listed here on the Viva Learning website, which you're going to be able to access here in a few days. I do want to mention, too, that, again, I'm going to take some question and answers here in just a little bit. But I want to mention that I use the products that I show here. I believe in the products. I found that I need not only a quality product, but a product that my staff is going to use and my staff's going to like. What I'd like to do at this point is I'd like to open it up to some questions. We're going to be available here for about 15 minutes. I'd be glad to answer any questions you have about safety, infection control protocol. So with that, I'm going to start taking some of the first questions. Here we go. Now, okay. Okay, first of all, some of the questions I have are this. What about, there's a question from a hygienist, and her question is about hand scrubbing versus using an ultrasonic or an instrument washer. What do I recommend? First of all, hand scrubbing is okay. Remember that you do have to be using, again, mask, gloves, nitrile, heavy-duty gloves, utility gloves, not the kind of gloves you use in the operatory. I am a real fan of using ultrasonics and instrument washers. Anytime I can use a mechanical device to make it safer, I will. Now, one of the people mentioned here, spray wipe spray, the leather chairs could be destroyed. It's true. What you want to do is you want to pick a product that's not going to destroy your chair. It would be a big mistake to be spraying an intermediate level disinfectant or to be wiping a chair with an intermediate level disinfectant between patients. That will destroy it. Instead, you might want to do what I do. I put a chair back cover on. They're inexpensive. It's a plastic barrier that goes over the back. I only use an intermediate level disinfectant on my chair if it's visibly contaminated with blood or saliva. Other than that, I happen to use a product from Clorox. It's a low-level disinfecting wipe, and it's very kind to the chairs. So again, read the label. I have a question here. I work in an orthodontic office. I work as an assistant. Want to know the best way to disinfect or treat a wire that's been dropped on the floor. Well, you know, when you stop and think about it, saying here that she says that what they've been using is they've been using Cavicide wipes and then using tap water and hand soap to rinse. My feeling is this: if a wire is dropped on the floor, okay, this is an item that's going to be going into the mouth. It would be my suggestion that that wire be wiped with an intermediate level disinfectant rinse before it's used. I have a question here. My doctor wants to use alcohol on the intraoral cameras and X-ray sensors. Is this acceptable? What I would do is I always recommend on the X-ray sensor and on the intraoral camera reading the instructions for use that came with them. That being said, I will tell you that I believe that the protocol should be, and this is what the CDC states, number one, a barrier product over that X-ray sensor, and number two, in addition to throwing away that barrier, to wipe that with an intermediate level disinfectant before you barrier wrap it again. That's what you need to do it the right way. Someone also mentioned, this is a good point, the laboratory. What about impressions? One of the things that you want to do is, it's really your responsibility, and it's outlined by the CDC, that before you send any impressions or models or bites or anything of that nature to the laboratory, they need to be disinfected. What do? I happen to use Clorox Broad Spectrum. We actually spray it with the product. It's an intermediate level disinfectant. We let it set for a couple minutes. We rinse it off. It's sent to the laboratory. And remember that things need to be labeled when they're sent to the lab, so the people in the lab know that, in fact, they've been disinfected with an intermediate level disinfectant. Patient or someone mentions here, says, I'm an RDA in a general practice. How do you recommend sterilizing sunglasses we use for the patients? Myself, I use the Clorox disinfecting wipes because they're very kind to plastic. They're a low-level disinfectant. They won't destroy the glasses. And also, I'm really glad to see that you're using glasses for the patients, because that is the standard of care. Patients need to be protected, not just the staff, but before anybody sits in a chair, they need to have a pair of safety glasses on. Someone mentions here cold sterile. Would that be glutaraldehyde? It could be. That's one of the compounds, or one of the chemicals used for cold sterilization. How often should it be changed? Well, you want to follow the manufacturer's instructions. You'll see instructions on the bottle. I am not a real fan of cold sterilization at all. Unlike an autoclave, you can't monitor it. You don't know how old it is. It needs to be proper temperature. I'm not a fan. Whenever I can use heat sterilization, that's what I suggest. We do have a lot of questions. I will tell you that when it comes to, someone asked here, what products would you recommend for disinfecting office areas and reception areas? Again, I'm a real fan there of using something that's not going to destroy my waiting room furniture. On the countertops, the armrest, etc., I choose Clorox disinfecting wipes. It's a low-level disinfectant that's very safe to wood and varnishes and surfaces. It's also very effective against things like MRSA, things that you might encounter in a waiting room. I have here that, again, people are asking about alcohol. No, you can't really count on just using alcohol wipes to disinfect. Any recommendations for products made for cleaning equipment touch screens? Again, I seem to keep saying the same thing, but it's a good answer, and you need to know. I happen to choose Clorox disinfecting wipes because I don't want to use, for example, the VersaSure product or the broad spectrum. That's my go-to for intermediate level disinfection. That's in the operatory. If I'm going to touch a screen, I want to touch it with something that's kind to plastics. That's why I choose the Clorox disinfecting wipes. It says here, is it still recommended to sterilize known hepatitis cases prior to running through an ultrasonic and then running through ultrasonic and re-sterilizing? Now remember that what you want to do is you really want to incorporate what I call standard precautions. That means since you don't know who has hepatitis and who doesn't, let's assume every impression has hepatitis potentially on it. That's why I want to use the same protocol, and that is I rinse it off, I spray it, in this case with the Clorox broad spectrum. I let it set for the contact time, I rinse it off. No need to do it multiple times, do the same thing all the time. In fact, a question here, Hormaz asks, are the Clorox products less likely than other products like Decide to be caustic in cases of incidental skin contact? Well, that is one thing I like about the products. The products are quite safe. The answer really is yes. I particularly like the fact that they have the STAR system on them that lets me know about surface compatibility. Here we have, gosh, that takes a question. How can I test surfaces in the office for contamination? You know, you really don't need to do that. You could certainly culture. For example, you could do like they did at the University of Arizona for that study. You could actually take swabs and culture and see what type of bacteria you have, but there's no need. I can guarantee you, when you look at the study I showed you here that shows that 76% of armchairs in the waiting room had some of these coliform or non-coliform bacteria on them, you can just automatically assume that your waiting room is no different than the rest of the world. Save your money. Just simply buy a good compatible product. Again, my suggestion are the Clorox disinfecting wipes for the waiting room, and disinfect them. Maybe your protocol is to do it once a day. That's what ours happens to be. Another question here. How different is the CaviWipe from the Clorox products? Well, I think the difference is, I think the CaviWipes were certainly a good product in their day, but I'd call the Clorox products a new generation products, improved chemistry. I like the fact that the Clorox products that I use are approved as a one-step. That's a real convenience. That really saves a lot of time. It makes it easy for staff. I also like the fact that they're extremely wet, so when I wipe the surface, it stays wet for the contact time. Question says here, can disinfectants be used for hand pieces? No, they really can't. Absolutely, the standard of care for hand pieces is heat sterilization. So the days of disinfecting hand pieces with disinfectant, spraying it or wiping it is gone. Absolutely, the standard of care that any court of law and any state dental board is going to hold you to is heat sterilization. Someone asked me a question here, what product do I usually use for a semi-critical item? And again, a semi-critical item is an item that is likely to touch mucous membranes or non-intact skin. So typical mucous membrane, of course, is the inside of the mouth. What I do is I consider that heat sterilization for any semi-critical item. I mean, to me, I really don't find items today that I can't sterilize. If it had to be something like, say, a cheek retractor or something of that nature, that's when I would use a high-level disinfectant, a so-called cold sterilant. Says if an instrument is left sealed in an autoclave bag on the countertop during the dental procedure, what is the recommended procedure to return the instrument? In other words, should the instrument be re-autoclaved? Well, see, here's the problem. The bag would be sealed. I'm assuming that it hasn't been opened, so the bag is sealed. But now you've contaminated the surfaces. There's aerosols in those operatories, okay? So now the outside of the bag is contaminated. What my solution would be first of all, try not to bring anything in there unless you know you're going to use it. If you don't use it, would I re-autoclave it? I would, because I want the outside of the bag to be clean. I just think that's good infection protocol. Good, I got a lot of good comments here. People like it. I try to be practical. That's what I really like. Again, I am actually a practicing dentist. So he says here, so you don't really use cold sterile at all. I really don't. I really prefer to use things that are single-use items I can throw away or things that I can autoclave. And you shouldn't have any trouble today finding plastics, like, for example, cheek retractors that are autoclavable. I have a question here about, let's see here. Is cold sterilizing monojets enough? No, it really isn't. If you're talking really, I'm assuming you're talking about a monojet syringe, a disposable syringe. Again, it's disposable. Do phosphoRadiographic plates require two-step disinfection similar to radiographic sensors? Is a single sealed barrier wrap acceptable? It's the same thing. You're going to want to not only have a barrier wrap, but use an intermediate level disinfectant on it. That's the protocol. Do you run water through a handpiece after use on a patient? Yes, actually what you want to do is this. When you take that handpiece off, obviously you're going to be sterilizing it. But as the CDC recommends, quote unquote, you want to run water 20 to 30 seconds between patients. So what I would typically do is I take that handpiece off, and when I put on the new handpiece, when I'm, obviously the room's been cleaned, turned around, I'm going to run that handpiece for about 20 seconds. It's just like in the morning when you take a drink. Run that faucet for a little bit first. It's that water that's been sitting in there that's the biggest problem. Is it okay to just spray off the X-ray positioners, the RIN rings, or should they be sterilized? They should be sterilized. They really should. Most all of those things are autoclavable. And again, if you can heat sterilize, that's the standard of care to which you're being held. And I don't want to see any of you get into trouble. Somebody claims they got an infection in your office, even though they didn't, only to find out that you're not heat sterilizing things that could be heat sterilized. I want to protect your business. What do I think of a dry heat autoclave? The only problem with dry heat is the fact that it has to be at such high temperature. I really prefer steam and heat, which is, of course, an autoclave. I really want to thank everybody for attending. A lot of people stayed on. We're really almost everybody stayed on. The numbers, if anything, have gone up.